My name's Hani Mowafi. I'm based at Yale now. I was previously at Boston Medical Center, trained in Virginia. I feel like I have kind of bridged two very separate worlds. Like the people immediately preceding me were the people that kind of started global EM, and there wasn't any global EM. They were the pioneers, and then the kind of several years later, the people after me, you guys are all coming in with so much experience, even as medical students, as residents, opportunities to do stuff in the field that we never really had. So I feel like some of this you might already be aware of. Many of you may have already participated in kind of humanitarian operations, but this is going to be a bit of an overview talk, and hopefully we'll have some time at the end to chit chat. In order to talk about the role of emergency medicine in humanitarian action, I feel like it's really important to actually understand a little bit the history of humanitarian action and understand how these different organizations interface with each other. We'll talk about the different types of emergency medicine engagement that people can expect are opportunities in your future. We'll talk a little bit about the professionalization of humanitarian health, and then some of the coordination and research that is ongoing. So, the drunk history of humanitarian health. So I will not be drinking anything. I will not judge any of you for imbibing this late in the afternoon. But the reason this is going to be kind of a drunk history of humanitarian health, because it will necessarily be brief. It will be incomplete. It will hopefully hit the high notes, and we're not going to take ourselves too seriously. It's late in the day, and you guys are zoomed out, I'm sure. So if you have questions, stop me. Like we'll be able to get through this together. So the brief timeline of the history of humanitarian health. Obviously, there have always been charity organizations, most of which were faith-based or related to like some sovereign group, whatever they were. But in 1859, this businessman named Henry Dunant, is a Swiss businessman, was outside of a town called Solferino, Italy, where he was making a business appeal, if you can believe it, to Napoleon, who was in the field with his army. And he witnessed what was a pretty vicious battle, and then the suffering of all of these soldiers that were essentially left to die and suffer in the field. And their care for these soldiers was largely the responsibility of the local villagers, and everybody was afraid to care for any soldiers lest they be targeted by the opposing group. So this left a very strong impression on him. He wrote a book, I think, Memories of Solferino in 1859, and that this kind of started a movement which led to the foundation of the ICRC, the International Committee for the Red Cross, and now Red Cross and Red Crescent societies. And the main goal initially was to be an impartial group that provided care to wounded soldiers and prisoners of war on both sides of a conflict, right? This was like a persistent problem. It was present. There were lots and lots and lots of wars and smaller conflicts that were ongoing, and this was always an issue. So the idea was, could we, create an organization that through its impartiality would be given access, humanitarian access, to take care of these people as human beings. So the ICRC was the dominant player for a very long time throughout the late 19th century up through the beginning of the 20th century, when we had World War I, which was supposed to be the war to end all wars, and we know that that wasn't the case. But when World War I ended, this was kind of the late 19th century period. Is many people call it the imperial period of humanitarian action. Most humanitarian assistance or relief was provided by colonial powers, really to kind of stave off revolt in their colonial possessions. At the end of World War I, certainly there were still some colonial powers in play for probably another 50 years. But this interwar period was really characterized by the first very large-scale international organizations. So in other than ICRC. So Save the Children was founded in 1919, with it being really the first large NGO focused on caring for civilians, right? So not necessarily prisoners of war, wounded warriors, rather just children, and it focused on there were many children and orphans that were victims of the Great Flu pandemic, so a little tie-in to what we're going through now, but also various famines. In 1921, what was the League of Nations eventually turned into the United Nations after World War II. The League of Nations, there was a High Commissioner for Refugees. This was really for the Russians who were refugees after the Soviet Revolution, the Russian Revolution. Their mandate was expanded to cover the Armenians who were displaced after the Armenian genocide, and it became this standing agency because we kept having problems of people being displaced around the world. Flash forward to 1945, the end of World War II, the Universal Declaration of Human Rights in 1945, and in 1949 we have the first Geneva Conventions. Again, we talk about Geneva Conventions a lot in humanitarian action, but most of what the Geneva Conventions were concerned with was how to humanely deal with your captives during war, right? So not necessarily, the few conventions that are really speaking to civilians that we frequently talk about are saying that care for them is the responsibility of the warring parties, specifically the ones who are occupying the area in which these civilians are in place. This is the status quo for many, many years until about 1971. Now we think of ICRC also as having a healthcare role, right? The Red Cross, we think of that as a symbol of doctors and healthcare. But actually the ICRC was really about reunification of soldiers and families, and passing communication to prisoners of war and making sure that they weren't being tortured. It really wasn't about healthcare. And they occasionally provided explicit health services. And one of the times that they needed to get some health services was in 1971. There was a breakaway state in Nigeria called Biafra. And that Biafran conflict with the Nigerian army and the Nigerian government at large was pretty brutal. And ICRC decided that they really, there were people saying that there was going to be widespread famine. There was concern that people would die for lack of simple medicine and vaccine preventable illness. So ICRC decided to recruit some physicians that would actually go and provide this care, including Bernard Kouchner, who was at the time, I believe, a resident, like a graduate medical trainee. He's one of the founders of MSF, and several other doctors that were there with them. And what they witnessed really affected them. And they felt complicit providing humanitarian healthcare in that setting, but remaining quiet about what they thought were pretty severe human rights abuses. And ICRC has a very strict rule about neutrality and impartiality. And the reason is because they're afraid if they come out and name and shame, then they will lose access to these prisoners of war, for example. They will lose access to these communities under siege. So they won't be able to verify and make sure that, that these people are okay. But these doctors really felt that they could not simply observe these violations and not speak out. They founded MSF, which was a really, it had a different flavor, because it was not just their founding ethos was not that they had a duty to act, but they had a duty to act and to speak out, to bear witness, right? So that takes us up to the end of the Cold War, the fall of the Berlin Wall that you see there. And up until this point, most conflicts in the world were mediated by great powers, right? So you had the United States and its proxies and the Soviet Union and its proxies. A lot of humanitarian assistance was provided directly by these groups to their teams, as it were. But when, with the fall of the Soviet Union, the Cold War dynamic was not in place, you started to have many smaller conflicts between countries, as well as intra-country conflicts. So civil conflicts between different groups within a country, which raises issues of sovereignty. And oftentimes, the United States did not directly intervene or directly provide assistance. So this left a gap, like a lot of the care that had previously been provided by governments. Suddenly there was this need for care, and not a lot of people to provide it. So you had a massive upswing in humanitarian health NGOs, right? And those NGOs they ranged from, Doctors Without Borders, ICRC, to like mom and pop grocery store and humanitarian NGO, right? So like there was a large span, both in terms of the number of agencies providing care, but also the quality of the care and the experience that they had working in the field. So it was felt that there was a need for standards, right? So in 1997, a project was launched called the Sphere Project, which is an all-encompassing effort, and we'll talk about it a little bit more in detail, to really define what are the elements of humanitarian care, humanitarian assistance, health and non-health humanitarian assistance, and then what are the definable metrics, and then what are the indicators that we are meeting or failing to achieve those standards. So this was the beginning of a whole period of professionalization of humanitarian health. So, like I said, there was a proliferation of NGOs. Charity groups had always existed. ICRC had existed for more than 100, 150 years. But the advantage of these NGOs is ostensibly they can provide assistance indirectly inside another country, right? So, from a neutral standpoint, I'm not here with the government, I'm not here with the fighters, I'm here to take care of people. But we know that providing assistance inevitably becomes political, right? And we know and we know that in some places the government is so collapsed that the NGOs become kind of the NGO state, which is what people used to refer to Haiti in this hemisphere as an NGO state, because there were all of these NGOs acting in a somewhat uncoordinated fashion because there was not a very strong central government to direct them. Over time, these NGOs are equipped with professionals and logisticians, but they're not equipped with armies, and they're not equipped with security like an army. And as their assistance became politicized, they come under attack, right? So we know that providing healthcare, emergency healthcare in complex humanitarian crises is a dangerous game. This is actually a photo from Syria, this ambulance, and you see here, there are UN peacekeepers there, and there's this child soldier whose arm just strolling right by. So you end up with a scenario where there's really a lot of blurred lines, and it's difficult to hold non-state actors accountable when they attack healthcare workers. So I'm not sure if I can actually play. Oh, here we go. If I can play this. So this is by the Safeguarding Health Coalition, which actually has been trying to document different attacks and threats on healthcare. And this video, it kind of shows initially political and conflict, and then it goes through COVID and vaccination related incidents. I set the date range to be from December 2011 to now, the end of last month, November, to just get a sense of the number in the last 10 years. So in the last 10 years, we're looking at a total 5,150, right? So in the last 3,600 some odd days, there's 5,150 incidents of violence on healthcare workers, humanitarian healthcare workers throughout the world. You can see that it's largely concentrated in certain areas based on different, the conflict related is largely was Central Eastern Africa and the Middle East. The political stuff is a little bit broader, but the point is, up until the year before COVID, in 2019, there were 1,200 attacks on health workers, facilities, and transport in 20 countries with conflict, and 151 healthcare workers died. So that was in 2019. The situation, unfortunately, has gotten worse because while these conflicts have continued to rage, there's a lot of antipathy and fear around COVID-19, antipathy towards healthcare workers that are trying to provide services, COVID services, excuse me, during the crisis. So the situation has been dire. So we talked a little bit about this before. So here we go, the sphere standards. So what are the sphere standards? They're across several domains, WATSAN, food security, shelter, and health. You guys are most interested in health. I wanted to give you some examples of essentially how it works. So, if you look within the health domain, they have standards for the health system and standards for the health services, the essential healthcare that gets provided. Now, these standards, it's our job when we're working with agencies in the field to try to plan to meet these standards, to review the type of care that's being provided to see, where we are achieving and where we're failing to achieve. And then there's a set of indicators, and I just threw a couple examples up here. So the percentage of the population that can access primary healthcare within an hour's walk, for example, is a type of health service indicator, or the minimum number of inpatient beds per 10,000 people is a health service indicator. But when you talk about the actual delivery of healthcare, the percentage of children 6 months to 15 years who have measles vaccination or completion of a measles vaccine, at the time that you've completed your initial vaccination campaign, people who have received appropriate doses of vitamin A, children who have received their DPT shots. So if you're working in a refugee camp, measles is incredibly infectious and is a life-threatening illness to a lot of the population in the camp, many of whom may not be vaccinated, many of whom survived fine in their previous lives because they were dispersed in like low density rural communities, but now you're gathering all these people in a very tight space. And if there's even one case of measles, it'll run through the entire camp. So this is the type of thing that you would need to be not just aware of, but have a significant familiarity with if you're working as an emergency care practitioner in any of these humanitarian agencies. But what we realize is that, and this is a non-exhaustive list of things, what we realize is that there was a real need for like skill augmentation, right? So, being a doctor is not enough. And being even an emergency physician who's used to caring for a wide variety of patients and a wide variety of scenarios is not enough, right? We realize that there is additional training needed in things like sphere and humanitarian standards, in how to interface with different agencies, in the ways of working in a culturally competent sense in different with different people from different cultures, and recognizing the epidemiology of different events, right? So people think that you need tons of doctors, when there's a massive, tsunami or an earthquake. But the reality is most of the people that are going to die at the time of the event. And then it's really a public health effort to manage the kind of long-standing care of and the kind of consequent illnesses, consequent conditions that you see after the fact. You know, the trauma is done and gone at that point. So people started to realize, well, we need to actually create some programs where people get exposure and dedicated training. Now, some agencies like MSF have intensive training programs of their own, as well as very long initial field placements where you kind of get indoctrinated into the system. But there are also academic centers. You all are engaged in fellowships where you get exposure to these various global emergency medicine modalities. There are the Center for Research and Training in Disaster and Humanitarian Health and Global Health in Belgium. You've got the help course initially in Geneva that is now kind of franchised throughout the world. And there's several others that are up here and many more excellent ones that are not. So this is obviously a non-exhaustive list. Many of you are at programs that have a focus in humanitarian health, or at a program like mine where it's not the primary focus. Sorry about that, but it is still an important part of our training. So emergency, dealing with all of these different agencies requires a lot of coordination. In a humanitarian crisis, the UN stood up what they called the cluster system. And you see here for each of the domains, whether it's shelter, education, food insecurity, health, they have a lead UN agency. So WHO is the traditional lead for health of the health cluster. And in times of disaster is usually the one who's going to be there. But in rare instances, certain other agencies like UNHCR can also be the health lead. There are standing members of the interagency standing committee, and then there are other ad hoc members. This is kind of a non-exhaustive list of the types of partners there. You see academic partners, large NGO partners, and UN agencies. Increasingly, there's recognition about the importance of research in humanitarian crises, right? So there's an incredible amount of money spent on humanitarian crises, both in terms of assistance and post-conflict and post-emergency rebuilding. Currently, 1 in 6 children in the world lives in close proximity to a war. 84 million people currently have been forced to flee their homes and are currently displaced as of the data from last night. And roughly 200 million people are affected by natural disasters each year, right? So when we talk about health problems of that magnitude, there's very few areas in medicine that we would attempt to treat 200 million people, or we would recognize a cohort of 200 million people without, putting our knowledge to the test, right? You have to actually study it to understand what is working, what isn't working, what are the successful ways of treating people in humanitarian crises. So this along with the professionalization and formalization is another important area where emergency medicine is having an impact. This is a recent paper from a working group that the NIH Fogarty Center put together about health research in humanitarian crises. This was the kind of wraparound op-ed, but it was a special issue of BMJ Global Health, and they had several articles. But the idea is that it's an urgent imperative that even large research agencies like the NIH are taking to heart. Now, there's a bunch of different, I'm sorry, go ahead. Okay, so there's a bunch of different types of research, right? So there's, research is the kind of collecting of data and analyzing of data for a specific purpose. Now, I hesitate to include rapid assessment with research because it's not truly research in terms of it's not really controlling for a lot of different factors. However, it is the type of operational collection and data analysis that is really needed urgently at the time of a humanitarian crisis for planning, resource allocation, human resource deployment. So very frequently agencies land on the ground and they have to do a rapid assessment. It's a bone of contention with many disaster affected communities or conflict affected communities that each NGO would come and want to do their own rapid assessment, or each UN agency would come and do their own rapid assessment. So they feel like they're getting interviewed hundreds and hundreds of times, but then they say, but where is the healthcare? Where's the food? where are the tents? Where are the assistance? So it can actually result in some negative consequences from communities if you're doing so many rapid assessments. And that's part of the importance of the coordination through the health cluster, where certain agencies coordinate together to do their rapid assessment, that gets shared, disseminated to all of the agencies within the health cluster, so that you can have a defined set of needs that then gets revisited at regular intervals rather than ad hoc. And when you're lucky that your rapid assessments look like this, where you arrive and you're wearing a UN agency vest that's clearly demarcated and you're surrounded by blue helmeted soldiers that are there for your protection. But frequently it's like this, where you are wearing a t-shirt and standing, writing, taking notes down on the top of the hood of a Jeep, because the resources that are dedicated to the initial rapid assessment are not as great as the need. This was now, I'm embarrassed to say, 15 years ago in southern Ethiopia, where there was kind of an internal conflict, and I was there with Oxfam doing a rapid assessment. But really, research in humanitarian emergencies. A lot of it is going to be on figuring out what is working and what is not. What is the natural course of different types of humanitarian crises, so that we know who are going to be the vulnerable people, who are going to be what are going to be the conditions that we can expect at various stages of a conflict or post-conflict scenario, a natural disaster, and what happens in its aftermath. And then also to assess the level of evidence, because it's very difficult to do research in these settings, as you can imagine. So we want to have a level of confidence that we assign to the findings that come out of the research. This is a paper that was in the Lancet that was looking at the number of papers that, it was a review of humanitarian health research, and but kind of by domain, the number of papers and the quality. And then I was trying to show you here, the post-disaster, where we can see the rise and fall of certain conditions, and so that you can understand how this helped inform. Now, this is not purely the domain of academic institutions. Certainly there is CRED, the Center for Research on and Epidemiology and Disasters in Belgium, the United States. There's lots of excellent university centers that are doing humanitarian health. Hopkins, where Bhakti is included. And I don't want to rattle off a long list, because there's many that are doing excellent work, and I don't want to leave anybody out. But the importance of doing this work is that you can demonstrate the impact on the communities, you can demonstrate differential impact on certain vulnerable subgroups, and you can look at the effect on the system and identify kind of what needs to be done to improve the systems post-conflict and post-emergency. But one of the other things that you can do, going back to the bearing witness that MSF talks about, is you can actually document some of the violations of humanitarian, international humanitarian law, and violations of the laws of war that routinely, unfortunately, still happen in modern conflicts. So, some agencies that do this, that emergency physicians have been very involved with, are Physicians for Human Rights and Amnesty International. Human Rights Watch tends to have slightly less of a health focus, but they also have been doing some health work. So, this is an example of a report that I was a part of back in 2011. It was in the aftermath of the Arab Spring revolutions, where this was, a few days after the fall of the Libyan government and before Muammar Gaddafi had been apprehended and ultimately killed by rebels, where we were there as part of a human rights investigation, but we also uncovered significant torture of health workers. And so this was actually at a camp that was like an old construction warehouse area that was being used. There were lots of horrible abuses there, but part of the investigation was not just kind of journalistic. There was actually a medical assessment. Similarly, it was part of a group that went with the Amnesty International to Bahrain when there were reports of attacks on not just protesters, but on the hospital that was caring for injured patients. Now, this is, again, not something that you're going to learn to do just in your emergency medicine residency, but many emergency physicians do take part in asylum examinations and training to do asylum examinations as part of their training, because many of you have access to centers for asylum medicine at your institutions. And most of those evaluations are based on something called the Istanbul Protocol, which is really a manual that was developed to document torture and degrading treatment. Lastly, I'll talk about the funding for humanitarian health, because this is a bright note that's on the horizon. It's not on the horizon. It's here, but it's growing. Several years ago, when we first started out, you couldn't get funds for doing this type of research, largely because the agencies that would provide assistance would say, well, we'd rather just spend that money on more tents or more food or more, vaccination than to study, or they would only want to study things that dealt with the efficiency of the service provision, not necessarily of the health outcomes or the systems outcomes on these communities. But over time, there were consortia that developed between different funders that ultimately resulted in things like the Research for Health and Humanitarian Crises, R2HC. So many humanitarian health research projects led by emergency physicians have been funded through this R2HC mechanism. It's based out of the UK. And then more recently, the UK Foreign Office and Development Office, along with the Government of Netherlands, along with the Global Affairs in Canada and Grand Challenges Canada, put together this Creating Hope in Conflict, which is a humanitarian grand challenge that is on offer now for anybody that has ideas to address certain large challenges in humanitarian health. So the idea that you could do this as a career is becoming more and more a reality for more and more people, and not purely something that you're doing alongside your academic or private work. So this is a company that that came out of the Canadian Grand Challenges, that I'm on their advisory board, where it's really a simple device that they developed, a small hand-powered negative pressure wound vac. So we know the machine wound vacs. We know putting a sponge on a patient's open wound and sticking it to wall suction, but this came out of a partnership that I had with certain physicians providing healthcare inside Syria, and I was helping them analyze their data and helping them plan their provision of health services. And then one of the things that they were seeing was, we can't keep people in the hospital because the hospitals are under attack. People come in from these, bombs that are being dropped in these civilian areas. They come in with these horrible open wounds. The ones that survive were able to kind of close down their wounds a little bit, but frequently, it's not even amenable to a skin graft yet. It's heavily contaminated. And if we keep them in the hospital, A, we won't have a bed to treat the new patients, and B, the hospitals are under attack, they might die here. So they send them home to convalesce with really kind of unreasonably, open wounds that are prone to infection. And they were looking for a cost-effective way that they could provide treatment to people in a war zone. And they came up with this, fairly powerful hand-powered vac with some simple instructions for how people could manage it themselves when it loses suction. And they're currently doing, a pragmatic trial to prove this. But anecdotally, they were showing massive reduction in the size of the open wounds that made them amenable to closure, which is a big deal for somebody who is in a war zone, and also somebody who is displaced. It's very difficult to have a significant medical issue when you don't have even a safe place to be. But beyond that, they also reduced significantly the number of people that were getting wound infections and sepsis. So this is a type of research that actually can impact people in the field during a humanitarian crisis. So again, the idea of professionalization is important, but still implementing, despite the fact that at this point, we're almost 20 years of implementing these types of certificate and graduate programs, of NGOs coordinating through the cluster, et cetera. But the earthquake in Haiti and the Ebola, the West African Ebola outbreaks were really a wake-up call that it's not just important to have, emergency physicians that also have public health training, that are have some experience working in the field. Ultimately, the first line of defense is a functioning health system, is like the door of the hospital, and that the hospital can be stood up to handle the initial wave. And then, even if you have these people out there in theory and in practice, you're unable to get them to where you need them at the time that you need them, then you still have a problem. So there was some analysis of the major humanitarian operations, the Haiti being a result of natural disaster, the West African Ebola being an infectious disease outbreak, but certainly the same is it can be said of many conflict-related emergencies, where there's a mismatch between the expertise, the availability of that expertise, and the ability to deploy it and coordinate between agencies. So out of that grew this effort to develop the WHO Health Emergencies program. This is, I basically, almost every single person that I've met through the WHO Health Emergencies program is an emergency care provider of some sort, either by training, by practice, or both. With the idea that WHO Emergencies mandate is to work with existing health systems to make sure that they are bolstered and strengthened to be able to withstand the initial shocks of these humanitarian crises, and then also to develop disaster medical teams that are trained, that know how to work together, and are deployable. So in the non-emergency times, they're working together to build up this roster, and they're making sure that they're trained, sometimes doing exercises, so that they are deployable during an emergency to actually bolster the existing health system, and then quickly transition services back to the existing health system. So many of you might be familiar with DMAT teams in the United States, the disaster medical assistance teams that are run by the government. Now, when they are deployed, the people that they pull up, who are largely quote unquote civilians, they're emergency physicians like you and me, they might be academics, they might be just working in private practice, or they might be from a variety of other specialties, that when they get pulled up, they are federalized, right? So they are deputized as federal workers, and they are sent as a US government disaster medical assistance team. So the idea of these EMT teams, these emergency medical teams, and it's unfortunate that the acronym is so similar to an acronym that we use for something else, was to create this kind of standing mechanism of rosters of people that have training that that can be recognized, that they can have reciprocal relationships, so that you can arrive in a country and have legal permission to provide medical care in that country, which is very important when you're an emergency physician. If you arrive in Brazil and you start practicing medicine and you don't have a Brazilian medical license, you better have some sort of pre-existing relationship that is going to define your role in an emergency, or you will be kind of legally and ethically liable. So the idea of these is to stand up these EMTs. They've been more successful in certain regions than others. PAHO has been, PAHO is the Pan American Health Organization, pre-existed the WHO. So the Americas region is PAHO, and they've been actually quite successful. And this is a screenshot from their dashboard showing where the different teams are based, where they've been deployed, the number of countries that have a national registration mechanism. We can see that one's lacking a little bit, but the number of mentors and mentoring groups that are there. So all of that is background. All of that, each of those slides probably could be, you know, a week or two of a course, but I wanted to give you guys a little bit of a heads up, because in the end, knowing all of the different opportunities that are out there for people to engage, then why us? Like, why emergency physicians, right? Well, first reason is that we're kind of the Swiss Army knife of the health system everywhere, right? So if you need somebody to take care of kids, we can do that. You need somebody to take care of the women, we're able to do that. You need somebody who understands how to do a variety of different procedures, we can do that. So we're very useful in the field in that way. We're also used to working under stress and areas where sometimes there is some level of disorganization. We are used to being the kind of crazy glue and duct tape that holds things together when other parts of the system are falling apart, right? I'm not going to read that list, but you understand that from your daily life, and certainly during the stress of COVID, all kinds of things go wrong, but the patient is still in front of you, and the patient is still acutely ill, and you have to figure it out, right? And so that makes us very useful, deployable in the field. We also, some of you who attended the talk several weeks back by Dr. Relin from WHO will recognize this slide of the emergency care systems framework. We also are the ones that are familiar with the entire health system from here, like in the field, at the house or at the side of the road where the accident happened, through ambulance transport, through arrival in the hospital, through admission to the operating theater or the ICU or the floor where people get their definitive care. And frequently we even understand what has to happen for people to get their follow-up care. So having this level of familiarity with health systems generally also makes us kind of uniquely positioned relative to our colleagues in other specialties for having that level of familiarity. But emergency medicine resident alone is not going to make you ready to be deployed in the field, right? There are certain other areas of additional training, additional expertise that you need to function properly in humanitarian setting, including training and experience in emergency public health, including the ability to assess populations and conduct population-based assessments, understanding the different types of health systems that exist in different parts of the world and the different medications and treatments that are used in different parts of the world. And these aren't things that you're going to get in a 3 or 4 year residency program. You don't even get it completely out of a global emergency medicine fellowship, but certainly having some level of additional training will make you more effective to be deployed in the field. Now, some of you are familiar with Buddhist koans, maybe others aren't, but I found a definition that said it's a paradoxical anecdote or riddle used in Zen Buddhism to demonstrate the inadequacy of logical reasoning and to provoke enlightenment. So I'm not going to claim that I'm going to provoke any of you to be enlightened or not enlightened here today, but I always was puzzled by this kind of circular problem in humanitarian health, which is that you have to have a certain level of experience to be in the field. But if you need all that experience to be in the field, how do you ever get experience in the first place, right? And I'm sure that I see all of you who have your cameras on nodding your heads, and I can imagine the ones that are with no camera on are also nodding, because everybody has faced this. I really want to go. I really want to help. I think I can be effective. I'm a quick study. I will patiently learn whatever it is that I need to learn, and nobody wants to give you a shot because they don't want to take on the responsibility of a trainee in the field who doesn't know the ropes. So, how do you do that? So you need to find a way around, not necessarily through. So sometimes that's volunteering with an NGO that is in a post-crisis environment, and sometimes they have more flexibility with the types of trainees that they will allow in the field, or recent graduates that they will allow in the field. And a post-crisis environment could be Gaza, right? So a post-crisis environment could be, the refugee camps that are on the border in Turkey or Lebanon or Jordan, where you're dealing with many of the same issues of a relatively fresh, in some places still ongoing conflict, but you are not in an active humanitarian crisis setting. So there's a little bit more leeway, seemingly, to get in. Frequently getting in with smaller NGOs, sometimes because they are desperate for your expertise, that they will have some flexibility. But the other thing is deployment through affiliation. So they might not be willing to take you as a first-year graduate from an emergency medicine program, but they might have a relationship with Dr. Hansodi, and when they call up Bhakti and say, well, we have this opportunity, and she says, this person is great, they're very smart, I trust them in the field, and I will be doing their pre-deployment prep, then you can get opportunities in certain in deployments in certain environments to go with certain agencies, which then are the experience that you need in the future, right? So that you're able to use that as a way, so that's deployment through affiliation. And then, honestly, sometimes it's just a roll of the dice. Some people happen to be working with, a non-humanitarian NGO, and they are on the ground when the shit hits the fan, right? And when things get bad, and you were there initially doing like a nutrition project, but now you have to do a rapid assessment about food security for this community that suffered this earthquake, say. So there are different types of deployments. There's long-term deployments, medium-term, short-term. So I just wanted to give you guys a little bit of a flavor here. MSF, this is a screen grab from their website, and then I clicked on a typical deployment requirements list, right? So it says compliance with essential requirements for all potential candidates, and we're not going to go through all of those here. You need to commit to work for a minimum of 9 to 12 months in the field. You need to have an MD and a current valid license, professional experience in a developing country or humanitarian context, minimum of 2 years post-residency, 6 months of clinical practice in the last 2 years. So don't be a retiree that hasn't touched a patient in a long time. Professional experience managing a staff, as well as clinical experience in one or more of the following areas. And there's a long list there, including emergency medicine. Oh yeah, and it would be nice if you spoke French or Arabic, if you had postgraduate study or degrees in international public health, refugee health, or tropical medicine, if you were an ID specialist, or if you're somebody who takes care of kids, right? So that's a pretty extensive list of requirements that most people are not going to meet, right? Now, is every single person who ever worked with MSF or IRC or one of these agencies, somebody who hits all of these? No, but they do their best to try to go for only those people. Now, some agencies, I was trying to scan through some to see which ones would have medium-term deployments. So Doctors of the World, Médecins du Monde, are initially in France, but then have different kind of local, national franchises, mainly in the UK, but in other countries as well. They allow shorter deployments. They're usually on the order of 2 to 6 months, but if they list their deployments in weeks, if they say 8 to 12 weeks, then you know that you're in good shape. If they list it in months, usually it's going to be a fairly long one. Or IMC, and I think this is Dr. Adam Levine from Brown. I came across a photo of him, I think, when he was still a fellow working with IMC. Now, the UN agencies can take you for these medium-term deployments as well, but they're usually going to go as a UN volunteer, and many of these agencies will allow shorter-term deployments, either for a specialty that is highly needed, sometimes for some of the surgical or anesthesia specialties and subspecialties, or sometimes for people that are return workers, where you have deployed with MSF in the past. They're very desperate for somebody to fill a certain position, and they're willing to take you for a shorter period while they look for the definitive person that's going to stand up their long-term center. So the short-term deployments that are professional are things that are like these disaster medical assistance teams that we talked about before. I strongly discourage, you guys are a subset that has already kind of identified the need for additional training before you go off into the field. I really don't encourage people to just pick up with their buddies and fly down to Haiti after the earthquake, or go with my church group to perform surgery for a week and then leave, because there's all kinds of ethical challenges with that type of healthcare, and you don't want to be freelancing without the necessary training or regulations to back you up. I can't actually see the chat. I see a couple things have popped into the chat. So if you guys, I just see the little notification. If you have a question, stop me. Like, I'm speaking quickly because I want to make sure you have time at the end for questions. If you have questions that you want to ask right now, stop me. There's only a couple more slides here in any case. Another opportunity for many of you who are interested is to do consultancy with a UN agency, either UNHCR, World Health Organization, or UNICEF. So I've done consultancies with these two. UNHCR was around Iraqi refugees in Jordan and Syria back in, after the Iraq War, and most recently working with the World Health Organization on the rollout of the Global Emergency and Trauma Care Initiative. I've not done health work with UNICEF, but I know other emergency physicians that have, and they have a variety of health programs that that you can do. It really helps to have an additional language. So if you do have an additional language already, kudos. If you don't, it's something that I would consider adding to your armamentarium, because it really makes you much more desirable for any of these agencies that want to bring somebody in from outside that has both technical skills and can be a fresh set of eyes that isn't already on their staff. So obviously you can do humanitarian health even if you're not engaged at one of these NGOs or UN agencies. And many of my colleagues in academic global emergency medicine are engaged in both supporting those NGOs in conducting research in humanitarian health and doing and in doing training. Long-term partnerships work better that combine both a mix of training and research. And it's important to not just be ethical, but try to be bi-directional, so that you're not just sending your trainees in the field to get experience without actually leaving something with that local community or with that NGO that they are working with. And quite frankly, it can be challenging to meet some of your professional milestones when you are engaged in humanitarian health. So I think it's important to be frank with you guys when you're doing this. If your time in the field is primarily engaged in service provision, you will definitely make your hospital newsletter. You will probably be like on the local news of this doctor who just returned from XYZ disaster, performing all of this excellent service to this community in need. But sometimes that doesn't align with the kind of more rigid academic milestones that we're trying to achieve for professional advancement at our home institutions. So I have a whole nother talk about how to make yourself an asset for your kind of where you're working as part, and how to make that to make your global emergency medicine career feasible. But suffice it to say that that it's something that requires your explicit attention. For other people, there's global health at home. Many of you are at medical centers that have refugee health programs where recently resettled persons are first interfacing with the health system. You will encounter many of the scenarios that you would encounter in the field, health problems that you don't routinely see in your institution, as well as some of the combination of both physical and mental health challenges that displaced persons are facing. It's a great way to get engaged on a longitudinal basis at your institution, especially now during COVID, before you get deployed in the field. Fewer universities have centers for asylum medicine, where people that are applying for asylum, first of all, do people understand the difference between asylum and asylees and refugees? Okay, so in general, all of these people are displaced. People that remain within national borders are IDPs, internally displaced people. People that cross international border are refugees, and asylees are people that once they are in another country request asylum because they have a credible fear of persecution or discrimination if they were to return home. So here at Yale, we have a Center for Asylum Medicine where they do intakes and take people's histories, and they do physical exams to kind of assess for any findings that are consistent with the histories of abuse or torture that they frequently report. Many of these centers for asylum medicine are run by emergency medicine physicians, or have emergency medicine physicians that are engaged. And here, Pooja Agarwal, who's in our section, is very involved with our Yale Center for Asylum Medicine. And then, unfortunately, another, it's not exactly at home, but it's right on our border. There are large, groups of people that are kind of piled up on our southern border right now because of the change in regulations regarding asylum from the previous administration that have now been extended under the public health acts because of COVID. So we now have a policy of, instead of having people come into the country and then declare their intent to request asylum, we are having them stay in Mexico. So you have large groups of people many of whom are fleeing violence from different parts of Latin America, South and Central America, who have made it up there and are now all in this kind of displaced persons camp on the border. And there are agencies, including MSF, but also this global global response management, excuse me, which is specifically engaged in providing that type of care. So in the future, things are going to look a lot more organized than they have in the past. They're already significantly more organized, but the idea is, as an emergency physician, you're going to have the opportunity, and somebody with the additional global emergency medicine fellowship training, you're getting the opportunity to work to strengthen the established health system, which is like some of the work that I'm doing with WHO right now. You're going to, some countries don't have emergency care systems. And so there's work helping establish emergency care in places where it doesn't exist. And there's certainly work, engaging in emergency and disaster response, either through the NGOs or UN agencies. And then there's work coordinating and researching all of this between them. Thank you guys very much. I hope you found it useful. I don't normally love talks where the speaker speaks continuously the whole time. So apologies if that was too much droning on, but if you have any questions that pop up later on, just feel free to email. Okay, take care.